Hi, everyone. Welcome to the Older Adult Falls Motor Vehicle Crash and Trauma-Informed Care poster session of the inaugural University of Michigan Injury Prevention Center Research Symposium. I'm Dr. Donovan Most, and I'll be moderating the session this afternoon. Thanks for joining us, and please excuse any growling you hear from my dogs in the background. We're glad that you're here. As a reminder, this session is being recorded and only the presenters and moderator are visible. Chat's disabled, so please use the Q&A feature for any questions. If you do have a question for our presenters, please type it in the Q&A feature in the bottom menu bar at any time. And if you could also please indicate who your question is for by including their name, the name of the presenter at the beginning of your question. Q&A will take place after all of the abstracts have been presented, but we do encourage you to send in questions as you think of them throughout the session. So we can have a chance to review them and answer as many as time allows at the end. Our presenters each have 4 minutes to present their poster, and we will share their poster slide while they're presenting. You can also access their posters and abstracts at the URL that's listed here on this opening slide for easier viewing. There are 5 poster sessions, 5 other poster sessions occurring at the same time. So as much as we'd love for you to stay in this session and listen to everyone, feel free to jump between sessions. Recordings of all sessions will be released in the coming weeks. Now, please join me in welcoming our presenters. I'll go ahead and introduce everyone now so we don't have to interrupt the flow during the presentations. Please welcome Dr. Daniel Kim from the Department of Healthcare Administration at Idaho State University, Dr. Jeffrey Hoffman from the School of Nursing at the University of Michigan, Lauro Ojeda from the Department of Mechanical Engineering at the University of Michigan, Sava Ganai from the Department of Public Health and Health Sciences at the University of Michigan Flint, Lauren Shaver from Wayne State University, Dr. Michelle Monroe Kramer from the School of Nursing at the University of Michigan, and finally, Dr. Hala Khalil from King Faisal Specialist Hospital and Research Center in the Department of Biostatistics and Epidemiology and Scientific Computing, all the way from Riyadh, Saudi Arabia. So Dr. Khalil gets the award for being with us from the most distant location. So with that, let's go ahead and begin.
Hi, everyone. I'm glad that all of you are here today. Like it was introduced, my name is Daniel Kim, and I'm here to present my research, which is titled The Effect of Health Literacy on Fall Prevention for the Elderly. So what exactly is health literacy? So for those of you that are not too familiar with the term, according to the Institute of Medicine, health literacy is defined as the individual's capacity to obtain, communicate, process, and understand basic health information and services to make appropriate health decisions. So what's really fascinating about the topic of health literacy is actually how little research is being done. Currently, we all know the whole topic of quality improvement has been this hot topic for a really long time, but health literacy not so much, even though health literacy plays a huge role in that. So for example, studies have shown that people with high health literacy levels tend to have shorter length of stay in the hospital, lower readmission status and complication status, because they're more likely to follow instructions that are given to them by their healthcare providers. So with 800,000 patients being hospitalized every year because of fall injuries, the purpose of this study was to examine the effect of health literacy on preventing possible fall injuries for older adults in the United States. And this study was just a literature review. So out of 239 articles that met the initial selection criteria, only 3 articles explicitly observed the effect of health literacy on fall prevention. So the first study conducted by Maurice et al. Found that many of the elderly who visited the ED due to fall injuries had relatively lower health literacy levels than those patients that did not. The second study conducted by Herman et al. Found that caregivers with low health literacy levels did not really adhere to injury prevention guidelines and was significantly, and that in and of itself was associated with some negative injury prevention behaviors. The last study conducted by Andrade et al. Found that health literacy intervention tool called Preventing Falls, I Can Do It, proved to be an improved manual for prevention of falls for older adults with low health literacy levels. So as these results show, it is clear that health literacy is not being extensively examined in the context of fall and injury preventions for the elderly. However, these three studies have shown that there is a significant relationship between patients' health literacy levels and their abilities to potentially prevent fall injuries. So by targeting patients' health literacy levels as a solution for the phenomena of fall injuries among elderly, the rate of fall injuries can be decreased and can ultimately result in better healthcare quality outcomes. So that's the gist of my project, and thank you for your time.
Hi, this is Jeffrey Hoffman. It's a pleasure to be here. So I'll be talking about falls and hospitalizations. I can't tell if I'm showing up on the screen here. Okay, well, I'll just keep going. So falls are common, costly, and debilitating for older adults. We also know that functional status and functional trajectories change around a hospitalization and get worse. But what we don't really know is are falls increasing around hospitalizations because of the care provided in the hospital, and so things are really focused on after the hospital stay, or is there a real increase in risk for falls right before the hospitalization as well? And in prior literature, there hasn't been a focus on examining the full trajectory of fall risk around a hospitalization. So what we did was look at 10,000 hospital discharges and a 12-month period anchored by the hospitalization to ask the question, how does fall risk change for older adults around a hospital stay? So we used health and retirement study and linked Medicare claims data for fees for about 4,100 older fee-for-service beneficiaries. We used a fall injury algorithm that we previously developed and validated using HRS and Medicare data with diagnosis codes and CPT outpatient codes and physician file codes. What we did was we divided this 12-month period that was anchored by hospitalization into 4 periods. The first was baseline, which was about a 5-month period. The next was the month prior to the hospital stay. The third period was right after the discharge from the hospital, and the fourth was a 5-month follow-up after that point. And what we did was estimate the risk, the weekly risk of a fall injury within each of those 4 unique periods to get an overall portrait of what fall risk looks like surrounding hospitalization. So if you look at figure 1, the overall predicted risk was about 0.8%. We can see from the figure that risk was mostly flat at the first 5-month baseline period, but then spiked right before the hospital stay, more than doubled the risk did. And then after the hospital stay in the month right afterwards, decreased substantially and then sort of flattened out in the long-term follow-up. When we ran the regressions, what we observed was that risk increased just slightly, about 3% in the baseline period, seen on the left of the chart, and then shot up about 30% by week, so 120% total in the month right before the hospital stay, and then decreased by about 10% by week after the hospital stay, and then flattened out afterwards in follow-up. We also looked at a high-risk group of patients who are vulnerable, who fell during the inpatient stay, and their risk of a fall injury spiked 10 times more than the general population. So overall, the study suggests that risks spike before a hospital stay and are not solely due to care during the hospital stay, but that also the risk is not mitigated during the hospital stay. Patients continue to fall afterwards. The implications are that fall prevention is typically siloed in different settings. What the study seems to call out for is a focus on transitions between care settings, perhaps a bundled care payment that can incentivize coordinated care across care settings to make sure that we're identifying risk pre-hospital as well as during the hospital stay and post-hospital whereas now we're characterizing and addressing these risks in siloed ways. Thank you so much.
Good afternoon. Thanks for joining us during this session. I'm going to be talking about losses of balance and falls. So we have been discussing this in the previous sessions, in the previous posters, but I just want to give you the statistics in a different way. So every 11 seconds, an adult is treated in the emergency room because of falls. And every 19 minutes, one person dies because of a fall. Now, in terms of economic impact, in 2015, there is an estimate that shows that it costs about $50 billion. Fall injuries cost $50 billion. And this is not a problem that is getting any better, because the statistics show that by 2030, 1 in 5 adults is going to be over 65 years old. Now, our objective has been to develop a method that will allow us to observe how these falls occur. Now, falls don't occur very often, but loss of balance happen often. So our effort has been on understanding losses of balance. The way how we did this is we tested our method, which uses inertial measurement units, or IMUs, with 11 participants. We also gave them a voice recorder. The inertial sensors were attached to the feet, to the trunk, and to the hand. Using this information that was collected over a period of two weeks, we were able to analyze it and determine the exact location of the occurrence of the loss of balance using the time indicated in the voice recorder. After this 2-week period, what we observed was we registered about 200 potential loss of balance. And just in terms of trips, we were able to observe 18 trips. Now, the way how this shows, or how we observe them, is as shown in this figure. You can clearly see the left and right foot velocity, and then eventually we see a disturbance in the trajectory of the feet. And this happens very often, and our main focus has been on the feet, knowing that some of the loss of balance may not have any motion shown on the feet. Out of these trajectories, we are able to corroborate them using the 3D animations. And then at the end, we have our physical therapists or technicians just looking at this information and the animation and making sure that we know or we learn more about this loss of balance and falls. And in these several weeks of data collection, we were able to capture 1 fall. Now, what we have demonstrated is that we have a method that seems to be feasible to identify trip-related or loss of balance in real world. And also it will help is with the development of algorithms for the automated detection of loss of balance. Okay, thank you.
I'm sorry about that. I'm Saba, and I'm honored to be here at the University of Michigan Injury Prevention Center to be presenting a poster here. So I'm going to talk about the lessons that we learned in recruitment and retention of older adults in Flint. So conducting research with older adults can be challenging, especially when it comes to recruiting participants from low-income communities. So the purpose was to describe our experiences in recruiting adults aged 65 and above who are living in Flint for our workability and social ties in fall prevention study. So what we did was we followed up with participants from our previous research study who were recruited from the Hamilton Clinic at that time. So as previous research has shown that utilizing multiple mode for recruiting participants increases the likelihood of potential participants in research studies. So we applied multiple strategies for study recruitments. The first one was mailing flyers to potential participants in their home addresses. And second was mailing 2 postcards separated by 2 weeks apart when there was no response from the flyers after 2 weeks. Then the third attempt was phone calls were made via telephone to the potential participants up to 3 times when there was no response from the flyers and no response from the postcards. So as a result, out of 140 potential participants, 20 had no contact information. So we approached 120 potential participants. So our overall response rate was 9.6 out of 104 known addresses and 2.06 out of 97 phone calls that we made. As a result, what we learned from this was that the use of flyers were more promising than the phone calls that we made, but it did not exactly increase the participation. So what we learned was like recruiting and retention of repeated measure studies are challenging in Flint, Michigan. Thank you.
Hello, my name is Lauren Shaver, and I will be presenting a qualitative analysis of patient recovery after trauma. So what we know about patient recovery after trauma is that many of the adverse outcomes are often linked and related. So the purpose of free text surveys as a tool to understand patient recovery from trauma was to understand the adverse post-traumatic neuropsychiatric sequelae, which includes post-traumatic stress, depression, post-concussion syndrome, and regional and widespread pain through the experiences of trauma survivors. This analysis is a secondary analysis from the Aurora study, in which a subset of 48 patients of the 1,601 patients in the study were analyzed. This group was identified as patients that often responded to the free text response survey questions, in which they were required to respond at least once to one of the questions in the 3 months, 8 weeks, and 2 weeks surveys. We found that we had high responses to the question of what was most important to understand about their experiences, with at 8 weeks, 98% responded, and at 3 months, 96% of the patients responded. Therefore, we were able to identify themes among patient responses. The major themes that we identified included resource concerns, emotional concerns, pain, memory loss, previous trauma, and study impact on recovery. Some of these themes we were able to then break down into minor themes based on high response rates. So for research concerns, we were able to break that down into financial, medical, or social support concerns. Emotional concerns, we were then able to break down into depression, anxiety, fear, stress, and hyperalertness. And then lastly, for study impact on recovery, we broke that down into positive and negative impacts. Therefore, we were able to understand that recovery after trauma for many patients persists for many months based on the responses at 2 weeks, 8 weeks, and 3 months, and that we were able to identify themes in these free text responses. We believe that this can be utilized in larger groups to qualitatively analyze patient recovery. Thank you.
Thank you for joining us this afternoon. My name is Michelle Monroe Kramer, and I am excited to tell you more about our research team's study on understanding student experiences with inappropriate, disrespectful, and coercive healthcare and physical exams. College students are a vulnerable population of emerging adults who are often learning to navigate healthcare and new types of social interactions for the first time. As college students learn to navigate the healthcare system, they may be vulnerable to abuse by providers who may exploit their lack of healthcare knowledge and lack of power. College students from oppressed groups may be at heightened risk of disrespect or abuse by providers. However, projects evaluating patient satisfaction have typically focused on the association between patient experiences and other measures of healthcare quality and are not intended to capture or identify verbal, physical, or sexual abuse or harassment. The purpose of this study is to gain a better understanding of the nature of inappropriate, disrespectful, and coercive, or what we will call IDC, interactions in healthcare, and to determine if college students are experiencing IDC from healthcare providers on or off campus at one large Midwestern university. In order to do this, we must first develop a tool to measure college students' IDC experiences in healthcare interactions. I will focus strictly on phase 1, the survey development in phase 2, but wanted to note that we also utilized a review of pre-existing complaint and satisfaction data from a university health service from 2011 to 2018 to help us understand the types of complaints student patients were making and the words they were using to describe these interactions. This work contributed to the development of the survey tool. In phase 1, we completed focus group discussions and individual interviews to understand how students perceive and describe IDC healthcare experiences. We completed 9 focus groups and then transitioned to virtual interviews when the COVID pandemic began, with a total of 38 students between November 2019 and May 2020. The themes that came from these qualitative interviews and focus groups included poor communication, including both verbal and nonverbal communication, a lack of cultural awareness among providers, institutional practices that made it difficult to know where to report problems, power imbalances, and a lack of patient empowerment. We used this information to create a survey tool informed by those student experiences. And we created a 60-item draft survey with a diverse research team, which included nursing, medicine, psychology, social work, as well as 2 student research assistants. Our survey tool had a variety of areas, including positive interactions, negative interactions, structural items, identity-based items, including some additional items specifically for transgender and non-binary participants, and sensitive exam items. In phase 2, we conducted cognitive interviews with 18 diverse students to ensure that the phrases, words, and response options were clear and made sense. Themes from the cognitive interviews included clarifying intent, adding inclusive examples, reducing redundancy, clarifying instructions, and modifying answer options. In conclusion, students are having IDC experiences that appear to be related to communication and DEI concerns and rarely include physical or sexual abuse. The development of this survey tool will allow for further research to understand the extent of IDC healthcare experiences among college students. The next step in our project is to pilot the survey tool at one large Midwestern university and then to hopefully do an evaluation of IDC at colleges and universities across the United States. Thank you very much.
Good afternoon to everyone. I'm delighted to share with you all results of one of our studies conducted in Saudi Arabia. There is actually a lack of local studies on the social impact of many chronic diseases in our country, which was what inspired our current project. We were interested to investigate patients with epilepsy and seizure disorder. And to study in depth their socioeconomic and occupational backgrounds. So we interviewed 534 adult patients with epilepsy using a structured questionnaire. One of the aims of the questionnaire was to capture the rates of driving among such patients and determine the proportion who would be considered fit or unfit to drive. We also examined whether driving status was affected by physician counseling or whether it was a factor of patients' own self-perceived risk. So we looked at 273 patients male patients who reported being physically able to drive a car. So if we start with table 1, we found that 58% of patients who would be considered unfit to drive by international guidelines. You can see the criteria we used at the footnote. So patients fit to drive were those who had no seizure in the last 6 months, those who only had partial seizure, and those who have seizures only while asleep. So around 60% of patients who would be unfit to drive at the time of the survey were actually driving, compared to around 75% of fit patients. Only 66% of these unfit patients perceived themselves at risk if they drove. We found socioeconomic differences in terms of employment status, educational level, and receipt of welfare between fit and unfit patients, which is most likely linked to the severity of the disease itself. Moving on to table 2, while 12% of patients fit to drive and 18 of those unfit to drive had seizure while driving, collisions were only reported by the unfit group. When we asked for history of seizures while driving by lifetime, 50% versus 60% of drivers reported seizures. Table 3 shows that most patients received counseling regarding safety of driving, around 70% of both fit and unfit patients. The most common reasons for not driving were physicians' advice, patients' own fears, and other advices. We run logistic regression, as you see in table 4, to test whether receiving counseling from a physician and self-perceived risk predicted if a patient would be driving. So for both fit and unfit patients, a self-perceived risk of driving significantly deterred patients from driving, while receiving counseling from a neurologist didn't show any effect. This is even after adjusting for socioeconomic factors. So we found these results very interesting, as they suggest that ultimately an individual's self-perceived risk dictated their decision to drive, while counseling by physician was not found to have any association. So in the prevention of motor vehicle collisions and injuries, our results may be a call to revisit counseling methods in the healthcare setting and sources of information used by patient, as well as being a call to employee wider strategies for health awareness. Thank you so much.
Thank you all so much for your presentations. If folks want to go ahead and turn their cameras, we can have everybody turn their cameras back on for the Q&A session. There aren't any questions in the Q&A, so if any one listening or if presenters have questions for other presenters, please put those in the Q&A box. So we can start. I'll go ahead and just go in the order of the presentation. So I'll start with Daniel Kim. I guess I'm curious, what do you think would be the mechanism whereby low health literacy is associated with increased risk of fall?
Well, I think the biggest reason is going back to the definition of the whole health literacy, right? I mean, the whole definition of health literacy is patients' ability to understand health information that are given to them. And also, it's also the term health literacy can be applied to physicians and healthcare providers as well. Their ability to provide those kind of information to the patients so that patients can easily understand those information and use them readily. And I think if those information can be given to them or can be provided to the patients in a way that patients can understand them more easily, it will be easier for them to follow the instructions that can potentially allow them to prevent the fall injury process. So I think that's one mechanism of how health literacy can have an impact on fall injury prevention.
Yeah, and I guess to what extent do you think it's the health literacy per se versus the characteristics of people who happen to have low health literacy and so probably they have more functional impairment, more medical comorbidity, which are things that would raise fall risk anyways. So how much do you think it's the health literacy in and of itself is a contributing factor?
I'm biased. I think health literacy has a huge impact. But to be honest, it's just I think that's a fascinating thing about health literacy, just the fact that there hasn't been a lot of research being done in the field of health literacy and how that has an impact on fall prevention, fall injury prevention. And I think an interesting project, the next step would be, okay, is there a correlation, running a regression, measuring those patients' health literacy levels to see if health literacy actually do have an impact on patients potentially getting those fall injuries or being able to prevent fall injuries, so on and so forth.
Great, thank you. For Dr. Hoffman, so clarify for me, was it the index hospitalization could have been a hospitalization for any condition, any reason?
Yeah, it's a good question. So, the concern is that some of the hospitalizations could be due to a fall injury themselves. And so we're seeing a spike simply because of that. And so what we did was allowed any hospitalization, but with the exception of fall injury. So if it were a fall injury, that was not included in that pre-hospital spike. So it's a really good insight.
And so is there a possibility that part of the escalating, so to what extent do you think the escalating fall risk pre-hospitalization is a function of people who are medically decompensating, and so maybe they're more at risk for some instability in a fall? Does that make sense at all?
I think so. I mean, the paradigm that's been applied to this previously is that it's bad care in the hospital, and I think there's lots of evidence for that. I think the competing hypothesis that had been unexplored is there's some sort of signal of acute decompensation. We can't, this analysis doesn't resolve that permanently in any way. It sort of gets us a few steps ahead, like a lot of research, because we didn't just look at people with acute decompensation. So, we can't sort of from this intuit findings about, like, if you fall, then you're going to be hospitalized or anything of that nature. I think what it does suggest is that sort of the iceberg syndrome or phenomenon where falls sort of represent a signal of underlying phenomena, and that people are coming to the hospital with these phenomena. So there more attention to this, to sort of prehabilitation, pre-hospital attention could be useful. If someone's falling before they have to go to the hospital, this might be a signal to clinical providers that more attention is needed.
And then one more. So I might not have absorbed the poster correctly, but I would have expected there would have, in the sort of time immediately following hospitalization, I would have thought the risk would have been higher for a fall than it appeared to be. Did I see that right? And any thoughts on why you don't see higher risk after hospitalization? Just because of the deconditioning, I would expect that people would be higher risk for fall post hospitalization.
Yeah. So it's a good question. In a previous paper that we've done, we found that fall injuries were one of the leading causes of readmission for older adults. It was the third leading diagnosis, and after heart failure and a few other things. And for high risk individuals, it was the leading readmission diagnosis. So there certainly are a lot of them. I think what this shows is that there is a spike in the immediate aftermath of the discharge. So weeks 1, it's sky high, but then it starts to go down. I think one potential explanation for that we couldn't dig into is something Neil Alexander brought up in his talk, which is when people get out of the hospital, they tend to, in qualitative work we've done, they tend to not move around as much. And so opportunities for falls decrease. So I think you're having more opportunities for falls potentially in the run up to the hospital stay. And so you see more falls. So the denominator is bigger, if you will, but afterwards that shrinks. And so you see lower falls doesn't necessarily mean less disability or less risk, if you will.
Gotcha. Thank you.
Thanks. Great question.
For Lauro, so is the idea that with the wearable sensors, so it seemed like in your process, you had both the sensor data, you had the 3D reconstruction, you had the audio recording. So you were sort of getting at near fall events by combining all of these data sources. Is the goal that you, based purely on the sensor data, could detect near fall events reliably? And are you at that point?
Yeah, so at the moment, we need the collaboration from the patients, from the subject. So they have to tell us when a loss of balance occurred or if fall had happened. So that helps us at least narrow down to a smaller window where we can go and start observing the signals and create these animations. Yeah, so at the moment it's not automated. It's we are finding those events. Now our time for identifying these events with all the tools that we have created has gone down from several hours to minutes now, but we still require the help from the patients.
Mm-hmm. I guess though, is the goal though that you would be able to get to the point where just based on the sensor data, you would be able to reliably identify the events?
Yes, so we hope to be able to do that, because I did mention that we captured 200 losses of balance. So that's a small data set, but it's a step in the direction towards getting the information that you may need to feed into a machine learning algorithm. And eventually, what we also know is that they are not reporting everything.
Mm-hmm.
And so ideally, we would like to be able to just rely on the sensor information, because we will be able to monitor them continuously for weeks, and then just have this fed into the machine learning algorithm, and then at least pinpoint the location of some of these events, and it can be assisted after that. So we can still use the human intervention just to verify that there was a loss of balance or a fall.
Yeah, I would imagine part of the challenge is what one person considers a near fall event worth commenting on, somebody else maybe doesn't. And so that is also part of the trick.
Yes, yeah, and we observe this very often. I mean, for some of the patients, we believe that every single step they are about to trip, and they report only some of them.
Right.
For some others, they feel very normal. They go in a parking lot, and then we see them just leaning towards one side and then start tripping or trying to catch up. So they are like pretty normal until something like that happens.
Yeah, great. Thank you very much. For Dr. Ganai, I guess based on the recruitment rates you presented, it was very small. Were you able to meet your target, and how were you able to meet the target? And I guess the second part is, for the project, did they expect the rate to be this low, or was this even lower than they anticipated?
So it was more lower than we anticipated. So we are thinking at least we reach about 80% of the participants, like the previous research participants. And the main reasons for that was because the recruitment strategies that we used was not quite effective for people, especially who are living in low income communities. So what we came up for right now is like going face to face with these participants and then recruiting them. But because of COVID, like restriction, we couldn't do that. So for right now, we're just pausing on this research, and then hopefully when the COVID is down, we are going to go and approach these participants again at the Hamilton community sites. And the other strategies that we're working on is like going to the health research portal sites and recruiting them through online. So that is another way that we are looking.
Great, thank you. For Lauren Schauer, can you talk about can you say, did participants need to have experienced a particular type of trauma?
Yes, so this study was a longitudinal study that specifically looked at patients that presented to the emergency department after some type of trauma. We were looking at patients that had more minor traumas that didn't require surgery or long-term stays in the hospital. So anyone that was discharged directly from the emergency department or discharged within 72 hours, we identified as potential patients for this study. We were trying to exclude certain things like surgeries and use of significant narcotics to prevent any with the effects on the CNS system and that potential impact that could have on a patient responses and the ability to do this study.
And so could the trauma have included like somebody in a bicycle accident, or was it more sort of interpersonal violence, or were there any type of restrictions or exclusions around the type of trauma?
No, we didn't exclude any specific types of trauma as long as they didn't constitute something that was too severe. So our primary traumas we looked at most of them were MBCs, also physical assaults. We had included minor falls, but falls over 10 feet we did not include because we considered those to be severe traumas. But those three were the main, but we did include other things like sexual assault, and so that was the major population there.
And so then, so you had contact with folks, I think it was three times after they were seen in the ED? To what extent did the needs people reported change? Did you see sort of an evolution in what people reported, or was it pretty consistent? What they reported at the first contact stayed to be the same as what they reported several months out?
Yeah, we saw overall that a good amount of people were consistent with their responses of what they thought was most important. We did see some change and also increases in the themes at the 3 months compared to the 8 weeks. We're hoping to look at more patients as when we were looking at this, there was a total of 1,600 patients in the study. We're hoping to look at that to see if we can see if there's any evolution, like you were saying, in the responses patients have.
Great, thank you. Let's see. So for Dr. Monroe Kramer, so there was a question actually in the Q&A, if you want to have a look at that. So the idea was, so I thought it was interesting in the first phase of your work, when you surveyed the college students, it didn't, if I recall correctly, no one reported experiencing event that they considered inappropriate, disrespectful, or coercive. But then it seemed like through the process, through the subsequent phases, you all did identify some sort of types of concerns or patterns of behavior that would have been consistent with the definition of IDC. And is that fair? Is that accurate?
Somewhat. I think our definition of IDC changed throughout the study. So we started this after the Nassar case and some of the other national cases, really focusing on like egregious physical or sexual abuse. And we did not have any of that reported. Instead, what we were hearing from students were more focused on communication, DEI issues, that maybe, that were kind of less of what we were looking for initially, but really is what the students were focused on as contributing to inappropriate or disrespectful care from their perspective. Okay.
So then there's a question comment about sort of the nexus between health literacy, and I think both from the provider perspective and the patient perspective, I think the idea would be, can you sort of maximize or promote health literacy in a way that you are also helping reduce the perception or the reality of IDC type of behaviors? Does that make sense? Do you want to comment on that?
Yeah, absolutely. So I think there's three levels, right? There's the individual student, and generally, college students have not had much experience seeking healthcare or navigating the healthcare system independently. They've often done that with a parent or guardian. And so a lot of it is education about what should be expected, especially in more sensitive exams that they may not have experienced before. And we focused on any healthcare provider, so we use that term very loosely. So it could have included a physical therapist, an athletic trainer, a psychologist. And so a lot of that is preparing them for what to expect during the exam. And some of that can come from the healthcare provider. And, our team believes we could do a better job of training healthcare professionals on that, really communicating and talking through the exams and why we're doing things, using patient-centered and trauma-informed care. And then I think the third level is the healthcare system. So the other part of it was when students felt uncomfortable about something, they didn't really know what to do and how to report that or get feedback on it. And so thinking about systems, really having a better system for reporting, following up with students, and not just focusing on like satisfaction, on a Likert scale, but really being able to explore those experiences in more detail.
Great. Do you have a timeline for when you'd like to sort of launch the survey and then subsequent work expanding
Yeah,
it?
we're hoping to launch the survey the next in 2021. So early 2021, we're planning on using basically sending it out through the registrar to a large number of students. It's something our team has done before with success. And then really getting understanding of how many students are experiencing this, as well as larger scale feedback on the survey. And then the hope would be to, kind of scale this up over the next couple of years.
Great, thank you. Is Dr. Khalil still on?
Yes.
Oh, there she is. So first I have to ask Dr. Khalil, what time is it for you?
Now it's almost 9 p.m.
Okay, so not too bad. So in the U.S., at least, most states have some type of law where physicians or drivers themselves have to report having had a seizure, and there's usually a period of time where someone's license is suspended and they're not supposed to be driving until they've gone a certain period of time seizure-free. Do you all have a policy or anything like that in Saudi Arabia?
Unfortunately, no, we don't have like a law for, like patients or, guidelines, shall the physician, report, that this patient, unfit to drive. There is no clear guidelines or legislation for this.
And do you have a sense, there are things that say clinicians are supposed to discuss with their patients that maybe frequently those conversations don't happen. Do you think most drivers who've experienced a seizure, do you think their physicians are in fact telling them they shouldn't drive? Like, do you think that conversation is happening in the first place?
Yeah, I believe they receive counseling from the physicians, but we don't know exactly what they tell them. There is no clear guidelines, even for the physicians themselves. So this is what we're trying to illustrate or get policymakers' attention to this.
Mm-hmm. And then I guess last question is, it seems like we're thinking a lot about this in the US these days, the idea of helping people understand risk level, and oftentimes people's beliefs and understanding of what their risk is related to a particular behavior doesn't actually match the facts of what their risk is for a particular behavior. So I'm curious if you have any thoughts about what might be a strategy to help people better understand their perception of risk.
I think in Saudi Arabia in general, we need to increase general health awareness. It's even for the public. We don't have we don't know the rate of wearing seatbelt. among people, among the public. So the health awareness should be, be a focus, and yes. And it's not only for this patient population, also for other chronic diseases, for like patients with diabetes, which is, very, we have high prevalence of patients with diabetes in Saudi Arabia. So we should look at this and to provide like a holistic care, not only, the medical part, to see other aspects of.
Great, thank you for presenting your work.
Thank you so much.
Dr. Hoffman had a question for Dr. Ojeda. Do you want to go ahead and ask yourself?
Sure, absolutely. Thanks, Donovan. Thanks for shouldering the load of all these questions. You're doing a great job. Yeah, Dr. Ojeda, I apologize if I misunderstood it. Sort of things were going quickly. There was a lot of really interesting information in your presentation. Did I understand correctly that sort of the ratio of trips to falls was pretty sizable, pretty large? And if that was correct, I thought it was maybe 200 to 1 for at least one of the examples you gave. I study falls just sort of way on the outside, not at the biomechanical level. And I'm always fascinated that surveys and health services researchers focus exclusively on falls, but don't pay much attention to trips, slips, and stumbles. And what we might be missing by not incorporating those sorts of questions into large surveys and whatnot. Could you just talk about like what if the ratio is so high from trips to stumbles, are trips important? Do we all have trips all the time? And I'm sure you would have a very long answer. This is not an easy yes/no question, but could you just talk about trips versus falls a little bit and why the ratio is like that and what we should be concerned about?
Yes. So we had 200 losses of balance reported. So, we could, in theory, analyze or observe all these 200 events. We only had one fall during that time. Now, remember that for some of these people, they fall once per year. So now, I don't think we have the statistical power to say, well, 200, you will get one LOB, one fall. At the same time, we know that not everything was a loss of balance and not all the losses of balance were reported. Now, having said that, we started another cohort a year ago with patients that were just any patients. So they did not report falls. And we just wanted to see, you could consider them control, but it was just a cohort of patients that we have the ability to test. After testing 2 of them, we observed almost nothing. So no losses of balance reported and nothing to observe. So we have to stop it there because otherwise it would have been a long summer. So yeah, so we're at the beginning of this.
Yeah, yes. Okay, fascinating. Thank you so much.
All right, so I don't see any more questions in the Q&A, and so I think we can go ahead and wrap things up. Thank you very much for joining us for this inaugural Injury Prevention Center Research Symposium. A big thank you to our presenters and Injury Prevention Center staff, in particular Matt and Danielle, for helping this go smoothly and keeping us all on time. As a reminder, all the sessions today were recorded and will be available on our website in the coming weeks. You'll be receiving a feedback survey within the next week. We encourage you to fill it out to help us continue to grow and improve this event in future years. If you're not already a member of the Injury Prevention Center, please go to our website at injurycenter.umich.edu to become one and get access to our monthly newsletter with publications, updates, and events. We also want to encourage you to attend our Suicide Prevention Summit, which will be held virtually on March the 16th. You can RSVP for this event on the events page on our website. We are also accepting abstracts for this event. Please check out our website for more information and opportunities that might interest you or your colleagues, such as our summer internship program or massive open online courses, or MOOC. Thank you again for your attendance, and thank you to all of our presenters for their important work in injury prevention. Hope you have a great rest of the day.